from Boston for a while. That's an inside joke. John is at the Ann and Robert H. Lurie Children's Hospital. John is the director of our Regenstein Cardiac Care Unit. John is one of those multiple boarded people, pediatric cardiology, critical care, pediatrics. Actually trained with us at Children's Memorial and then went to Boston, was an attending there in their CICU for about 8 years, and now he's been back for 2 years as the director of our unit. Has really, revolutionized the way we take care of our post-op patients. We've really appreciated all his input. All of our numbers have gotten better, our mortality, our infection rate, everything under John's leadership. So I asked John to talk to us about the CCU, and the title of his talk is what he's going to talk about, evidence-based medicine, truth versus dogma. So all this dogma that we all learned when we were fellows that, is now probably turning out to be incorrect. What do they say? 30% of what you learn in medical school is going to be wrong 10 years later. I already saw looking at his talk that I'm going to have to change the way I do steroids in my patients. So, John, take it away.
All right, thank you, Carl, and good morning, everyone. It's a pleasure to be here. I've got no disclosures, although I would, I'd say with the exception of the fact that I'm a little bit uncomfortable with the title of my talk in that, while I can certainly point out the dogma, I'm not sure I'm going to be able to deliver the truth to you. And certainly, Carl, if you invite me back in 5 or 6 years, I'm sure I'm going to have to delete and replace at least half of the slides in this talk as we learn more about these interesting topics. So during the time allotted, I thought there are a number of things I could talk about, but for the sake of time, I'm just going to focus on 3 issues. One is this issue of gestational age and birth weight in neonates with critical congenital heart disease. I'm also going to spend some time talking about perioperative glucose control, and we'll wrap up talking about the empiric use of corticosteroids and cardiopulmonary bypass. So we'll start off talking about gestational age, and to set the framework for my comments, we'll just briefly review the fact that both prematurity and low birth weight are known risk factors for adverse outcomes in neonates with critical congenital heart disease. As you all know, prematurity is typically defined as birth prior to 37 weeks completed gestation, and low birth weight is typically defined as a weight less than 2.5 kilograms. And I'm certainly not here to challenge the fact that patients meeting those criteria are at risk for adverse outcome. But what I would like to talk about is the dogma that patients who are born at full term, which is typically considered between 37 and 42 weeks gestation, or patients who have a birth weight greater than 2.5 kilograms, are not at risk for adverse outcomes. So there are a number of single-center studies in the literature demonstrating that prematurity is associated with adverse outcomes. Perhaps the best data on this topic, though, comes from the work that Kathy Jenkins did when she developed the RACS surgical risk categorization system. And this is a table from that paper that demonstrating, in addition to additional surgical complexity, younger age, and the presence of major non-cardiac structural anomalies, that patients who are born prematurely have roughly a 2-fold greater odds of hospital mortality. And this was a very large data set with over 4,000 patients from multiple different centers. There are many single-center series in the literature looking at low birth weight at the time of surgery. Perhaps the best data out there is this paper from Chris Cruzan and colleagues that was done using data from the STS database. These investigators looked at a number of commonly performed congenital operations in neonates with cardiac disease, breaking down the over 3,000 patients in this particular data set into those weighing between 1 and 2.5 kilos at birth, of which there were over 500, and the other group weighing between 2.5 and 4 kilos, of which there were just over 2,500 patients. And you can see that for nearly all of these operations, the risk of hospital mortality is significantly higher for those babies in the group weighing between 1 and 2.5 kilos. And for those few operations where there was statistical significance was not achieved, for example, pulmonary treason, TAC ventricular septum, some of that may have been driven by the fact that there were relatively small numbers of those patients in the data set undergoing that operation. So I got interested in this issue of gestational age of babies who are born at term and outcomes for neonates with critical congenital heart disease for a couple reasons. One is I just anecdotally observed a few patients who were electively delivered in the term period, but at 37 to 38 weeks gestation, without any fetal indication or without a maternal indication, but usually because the patients were coming from outlying states, and the clinicians wanted to have a controlled delivery and have the patients smoothly transferred into the CICU. And several of those, although many of those patients do fine, I observed a few patients have significant problems with, for example, respiratory distress syndrome in the preoperative period that resulted in major perioperative complications. And around that time period, I stumbled across this paper in pediatrics that was focusing on the outcomes for babies without cardiac disease or other birth defects who were born in the state of Utah. And in this data set, there were over 250,000 babies over a recent 5-year time period. And this particular table is focusing on the outcomes of babies who are born in the so-called late preterm period or near term, which is typically defined in the pediatric literature as 34 to 36 weeks gestation. And you can see that these babies have roughly a 3-fold greater odds of death in the first month of life compared to babies who are born at 39 or 40 weeks gestation. And again, these are babies without birth defects. But what caught my eye when I was reading this paper was the outcome of these babies who were born at 37 to 38 weeks. So these are in the so-called term period. And again, babies without birth defects appear to have roughly a 2-fold greater odds of death in the first month of life compared to babies who are born at 39 to 40 weeks gestation. And I was curious about this based on my anecdotal observations and the fact that we see many of these babies in our cardiac intensive care units were born with critical congenital heart disease at 37 to 38 weeks. So while I was still in Boston, we decided to look into this issue. In this study, we looked at 971 neonates who were born and admitted to our cardiac intensive care unit. The majority, about 90% of these patients, underwent cardiac surgery. There were nearly 100 patients in the data set who also underwent an interventional catheterization as their primary interventional procedure. And you can see the key outcomes from this study on the slide. So the x-axis has their gestational age, and the hospital mortality rates on the y-axis. And the first thing that should catch your eye is that there's this U-shaped relationship between gestational age and hospital mortality, with the lowest mortality in this 39 to 40 week group, about 2.6%. The mortality jumped up to 8% in the small number of babies. There were 50 who were born beyond 41 weeks gestation. And then the mortality was 6.9% in this relatively sizable group of patients, 360, who were born at 37 to 38 weeks. Again, these, if you look at these babies between 37 and 41 weeks, previously people really thought of these babies as being equal, all being born in the full term period. But when we subjected this to very careful multivariate analysis, adjusting for all of the usual suspects such as surgical complexity, presence of genetic syndromes or non-cardiac birth defects, we found that there was still a greater than 2-fold adjusted odds of death during the hospitalization for these babies born at 37 to 38 weeks gestation. So I certainly wasn't the only person who was thinking about this issue around that time period. This is a paper from Jim Snod and colleagues from Cincinnati Children's that was actually presented at the same AHA meeting as my abstract was presented several years ago. These investigators used linked birth and infant death cohort data sets from the National Center for Health Statistics between the years 2000 and 2003. So within this data set, there were 12.5 million live births that had occurred between 34 and 40 weeks gestation. From the death certificates, these investigators identified over 4,700 deaths that were attributed to congenital heart disease within the first year of life. And they then calculated the rate of death per 10,000 live births that was attributable to congenital heart disease, and then broke that down by week of gestational age. So in this top table, you can see the leftward column is the weeks of gestational age at birth, and then the second column here is the deaths that were attributable to congenital heart disease in this study per 10,000 live births. And you can see at 40 weeks there were 2.4 deaths, attributable congenital heart disease per 10,000 live births. That jumps up to 2.9 at 39 weeks, but that was not statistically significant. But as you continue to move on at 38 weeks, up to 4 per 10,000, statistically significant. 37 weeks, 5.7 per 10,000, again statistically significant. So there were limitations to both of these studies. The study that we conducted in Boston was a single-center study, so obviously those findings may not be generalizable. Obviously, we only included patients who made it to our cardiac intensive care unit, so this did not account for deaths that occurred prior to referral or institution. The study by Snada and colleagues from Cincinnati had a very large sample size. However, it was limited by the use of administrative data, and there was really no meaningful risk adjustment performed in that study. So to address some of those limitations, Dr. Backer and especially Marshall Jacobs, who's here today, brought a group of us together to look at gestational age and outcomes in the STS database. So we included neonates in this study who underwent cardiac surgery at less than 28 days of age. The cardiac operation had to be classifiable by the STS, EA, CTS mortality categories. And we included patients from calendar years 2010 to 2011. And the reason we did that is because gestational age was added for the first time to the STS database as a variable in the January of 2010. So in this study, which we just presented a few months ago at the ACC meeting, there were over 4,700 neonates included from 92 different STS centers in the United States. The key characteristics for these study patients are summarized on the slide here. I won't go through these in detail other to point out the fact that in our multivariable models, we adjusted for all of these variables in our analyses. So this slide summarizes the distribution of gestational age for these 4,700 neonates. The main point I wanted to make is that only half of these neonates are born between 39 to 40 weeks gestation, actually 48%. So the slight majority of the patients are born outside of this potential optimal range of gestational age. So this slide summarizes the hospital mortality for these patients broken down by gestational age. Overall, the mortality was 9.9%. But again, you see this U-shaped relationship with the lowest mortality at 40 weeks gestation. Now, this figure depicts the adjusted results after a very careful multivariate analysis. The reference point for the study was the combination of patients born at 39 to 40 weeks gestation. And you can see that there was a statistically significant adjusted increase in mortality for those patients born at 37 weeks gestation or before. So at 36 weeks, the adjusted odds ratio for hospital death was 1.5. At 37 weeks, it was 1.3. The 38-week group did not reach statistical significance, although the odds ratio was 1.2, nor did the group born at 41 weeks or after. We also looked carefully at the development of complications in this study. Approximately two-thirds of the patients overall, or 68%, developed one or more complications that were coded in the STS database. And again, following careful multivariate analysis, these patients born at 37 to 38 weeks had an increased adjusted odds ratio for having a complication during that initial hospitalization. We also looked at major complications. These would include things like ECMO, cardiopulmonary resuscitation, need for an unplanned reoperation, etc. And again, at 37 weeks, there was an increased adjusted odds for developing complications, but this was not significant at 38 weeks gestation. We also looked at length of stay for these patients and again found that patients born at 38 weeks or earlier had an increased adjusted postoperative length of stay. So being born at 38 weeks following multivariate analysis added nearly 4 days to the hospitalization, 37 weeks 2.6 days, and 38 weeks about a day and a half. There are limited data regarding late outcomes with with regards to gestational age in these neonates with critical congenital heart disease. This is one paper from Bill Gaynor's group in Philadelphia. However, that was interesting in that patients who were born before 40 weeks gestation had a increased issues with neurodevelopmental outcomes on multiple different domains in this study. So back to I referred to one study in my earlier comments about babies without birth defects. There are actually multiple studies that have been published in the last few years looking at the timing of delivery at term for babies without birth defects. And the message in all of these studies, which have been published both in the New England Journal of Medicine and also some of the prominent obstetrical journals, is the same. And that is there is a U-shaped relationship between gestational age at term and outcomes for these patients, not only in terms of mortality, but for a variety of other outcomes, such as the development of respiratory distress syndrome requiring surfactant, the need for admission to intensive care units, et cetera. So the message is very consistent in the literature that there's this U-shaped relationship at term with the best outcomes occurring at 39 to 40 weeks gestation. I've just got one slide about the issue of birth weight and timing of surgery. I mentioned earlier that cut point of 2.5 kilograms being associated with worst outcomes in the Cruzan study from the STS database. This is a recently published paper from the Toronto group that included over 1,600 neonates with critical congenital heart disease that were managed in their center. And the focus of this paper was not necessarily on the birth weight, but whether or not premature or low birth weight babies should be intervened upon early or fed and grown into a larger weight. And I'm not going to get into that issue for the sake of time, but I would challenge you to point out for me where the cut point for the optimal birth weight is on this slide. And I think my point is that it certainly doesn't appear to be at 2.5 kilograms, but rather there's a gradual decreased proportion of these babies who are alive at 1 year of age with lower birth weights. And whether one would place the cut point at 1.5 kilos, 2 kilos, or 2.5 kilos could easily be debated, or perhaps even 3 kilos. So what are the inferences from these data for our practice? Well, one is that these observational data suggest that optimal outcomes following neonatal cardiac surgery are associated with birth between 39 to 40 weeks gestational age. And as I just showed you, there's no clear transition point for a birth weight of 2.5 kilograms or less being associated with suboptimal outcomes. So I think these data may be useful for planning the timing of delivery of patients with congenital heart disease, for counseling the families once these babies are born, and importantly for risk adjustment and outcome analyses. So I think it's always better to at least start off using continuous or categorical variables such as the actual birth weight or the actual gestational age, rather than binary variables such as low birth weight versus not, or prematurity versus not. I think that some of the data, not just the pediatric cardiology data, but the data in babies without birth defects fairly clearly suggests that elective deliveries, and when I say elective, I mean there's not a fetal or a maternal indication to deliver that baby early prior to 39 weeks gestation, should be avoided. And obviously you as surgeons aren't on the front lines in terms of making decisions about when these babies are brought in, these moms are brought in and induced and whatnot, but I think you can carry this information back to your fetal cardiologist and your maternal fetal medicine specialist. One challenge we have is what to do with these babies once they're born, whether they're low birth weight or at an earlier gestational age, and we don't have the data right now to answer that question. So if a baby is born at 37 weeks gestation and needs a Norwood operation, for example, what's the ideal timing of surgery for that patient? We're going to need more data and more studies to figure that out. So I'm going to move on now and talk about glucose control in the perioperative period. Just to set the stage for these comments, stress hyperglycemia is a very common problem in critically ill patients, including children recovering from cardiac surgery. There are multiple studies showing that 90% or more of infants and children undergoing cardiac surgery have at least some time being hyperglycemic in the early postoperative period. So the historical dogma was that stress hyperglycemia was an adaptive response and potentially even beneficial in that cells that are not dependent on insulin to transport glucose, such as the brain, may benefit from higher glucose levels during periods of illness. So the dogma was that generally stress hyperglycemia was ignored unless it was causing an osmotic diuresis. So what causes this stress hyperglycemia? Well, a number of factors play into this. There are glucocorticoids and catecholamines, both those that are endogenously produced as stress hormones, but also exogenously administered drugs, both in the operating room and in the ICU. There's inflammation in critical illness and various cytokines and other factors that lead to insulin resistance. And then in addition to that, we commonly are administering dextrose, either in the form of IV fluids, TPN, or enteral feeds. And all of those things contribute to hyperglycemia in the critically ill patient. This can cause an osmotic diuresis, as I alluded to earlier. But the real concern here is the effects that the hyperglycemia may have in critically ill patients on cells, and particularly these cells that are not dependent on glucose not dependent on insulin for taking up glucose, such as endothelial cells, cells that are involved in the immune system, and neurons. And this hyperglycemic load can lead to mitochondrial injury, dysfunction of the immune system, including neutrophil function, endothelial dysfunction, oxidative stress, etc. And this, in critically ill patients, can accumulate in bouts of sepsis, prolonged mechanical ventilation, impaired wound healing, and a neuromyopathy, or a critical illness polyneuropathy. There is a fair bit of literature from the basic science labs and translational work suggesting that there are cardioprotective effects of insulin beyond its role in controlling hyperglycemia. So insulin has been shown in tissue preparations in the lab to have positive inotropic effects. It also has some direct anti-inflammatory effects. It induces endogenous nitric oxide synthase to increase the production of nitric oxide, which may have beneficial effects on regional coronary perfusion. And also, insulin has antioxidative properties and anti-apoptotic effects, all of which, in theory, should be beneficial for our infants and children who are undergoing cardiac surgery. So there have been multiple observational studies in critically ill adults that have demonstrated associations between hyperglycemia and adverse outcomes. I don't have time to go through those studies in detail today, but the key questions that they would raise is whether or not this hyperglycemia is causal in the pathway of injury, or whether it's just a marker of severity of illness, or in other words, will an intervention improve outcomes? And this topic of tight glycemic control really came to the forefront in the ICU communities, both pediatric and adult, with the publication of this trial by Gret Vandenberg and colleagues from Leuven in Belgium. So this was a trial now published over 10 years ago from a single center study. There were over 1,500 surgical ICU patients, and most of these were adults recovering from cardiac surgery, who were randomized to either intensive glucose control with a glucose target of 80 to 110 milligrams per deciliter, or standard care, which at the time meant that insulin was only administered if the glucose level was greater than 215 milligrams per deciliter, and those patients were targeted to a target range of 80 to 200. And what the investigators found was a significant reduction in mortality in those patients who were assigned to tight glycemic control. So the mortality in the tight glucose control group was 4.6% versus 8% in those patients who received conventional treatment. So a 42% relative reduction in mortality, which is really a striking finding for the adult ICU community. So this concept of tight glycemic control at that time really took off like gangbusters. It was quickly adopted in many ICUs, adult ICUs, that is, around the world. It was incorporated into guidelines that were published from a number of prominent societies. However, the data that unfolded over the next decade presented somewhat of a mixed message. So I've summarized on this slide a number of the major trials that were conducted following this 2001 Leuven trial, and in all cases they were unable to replicate this mortality benefit. Some of these studies were underpowered, others were flawed by excessively high rates of hypoglycemia in the interventional arm. And then along came this study, which was published in 2009, This was a multi-center adult ICU study, 42 different centers, over 6,000 patients who were projected to be in the intensive care unit for at least 3 days. And these patients were, again, randomized to intensive glucose control with a target of 81 to 108, or conventional therapy, this time with a little bit lower target, 144 to 180. And what these investigators found was quite interesting in that compared to conventional glucose control, those patients who were assigned to tight glycemic control arm actually had increased mortality, so 27.5% versus 24.9%, so a 2.6% absolute increase in mortality in those patients assigned to tight glycemic control. Many of these, there have been several meta-analyses that have attempted to pull these data together and understand the literature. And one message that seems to come out is that these studies that were conducted in Leuven, of which there were 2 of them by Gret Vandenberg and her team, those patients were heavily supported from a nutritional perspective with TPN, versus many of the studies that were not able to show a benefit in mortality were conducted in ICUs where the prominent strategy was to use enteral nutrition whenever possible. The other take-home message from pulling these data is the odds ratio for developing severe hyperglycemia in these adults, which was defined as a glucose level less than 40 with tight glycemic control, was approximately 7.7. So there's a real risk of hypoglycemia with this intervention. One more adult slide, and then we'll get to the pediatric data. This was a meta-analysis looking at some smaller trials that were conducted in adults undergoing cardiac surgery. And just briefly, this meta-analysis did tend to suggest that with tight glycemic control in adults undergoing cardiac surgery, there was a benefit not only in terms of mortality, but also in a reduction in postoperative atrial fibrillation, ICU length of stay, and the need for epicardial pacing in the early postoperative period. So with that backdrop, and I'll move you to the pediatric literature. There are probably a dozen now observational studies demonstrating strong statistical associations between hyperglycemia and adverse outcomes in infants and children undergoing cardiac surgery. I'll just tell you briefly about one of them that I was involved in with Angelo Polito and others while I was still out east. In this study, we looked at 378 patients undergoing complex congenital heart surgery, defined as having a RAX-1 category greater than 3. We looked at 6 different metrics of glucose control, both intraoperatively and in the early postoperative period, and then looked at 2 endpoints. The primary endpoint was postoperative hospital length of stay, and because the mortality was so low in this data set, we looked at a composite morbidity mortality endpoint that included things like ECMO, renal failure, mortality, things that have been associated in other patient populations with adverse outcomes in the setting of hyperglycemia. So the time-weighted, the glucose variables that we looked at included a time-weighted glucose average. We also looked at patients having a peak glucose greater than 200. We looked at standard deviation of the glucose as a measure of glucose variability, which is also a topic of interest for people who are looking at this, minimal glucose levels, and then the duration of hyperglycemia, broken down by glucose duration, number of hours in the first 3 days after surgery with a glucose greater than 126 and 200. And for the intraoperative data, the only thing that was statistically significant was having a minimal glucose level in the operating room less than 75 was associated with the composite morbidity mortality outcome measure, but there was no association between intraoperative glucose levels and hospital length of stay. And this is probably not terribly surprising given the relatively short time period these patients are in the operating room relative to the rest of their hospitalization. In the postoperative period, we had a couple of significant findings. First, with this time-weighted glucose average, actually the best group tended to be patients who were slightly hyperglycemic, 110 to 126, compared to those patients who had a low glucose, relatively low time-weighted glucose average, less than 109, which would be considered normal glycemic. They had a 7-fold greater adjusted odds of reaching that composite morbidity mortality endpoint, as did patients who had a time-weighted glucose average greater than 143, of which the adjusted odds was for reaching the endpoint was 5.2. And we also found that patients who had a peak glucose greater than 250 had a statistical association with having worse outcomes, as did those at a minimal glucose level less than 25. And again, this is after a very detailed multivariable analysis. As far as hospital length of stay, the only glucose metric that was associated with longer length of stay was the amount of time patients spent with a glucose level greater than 126 milligrams per deciliter. So again, there are about 10 other papers in the literature that basically, in one way or other, convey that same message. So we were fortunate that the investigators in Leuven who published that 2001 New England Journal of Medicine trial decided to carry on that concept and study patients in their pediatric ICU. So this was a single-center PICU study with patients who were admitted to the ICU and anticipated to be in that unit for at least 24 hours. And importantly for this audience, 75% of the patients who were enrolled in this trial had undergone cardiac surgery. They were randomized to either tight glycemic control in the early postoperative period or conventional care in which glucose wasn't treated unless it was greater than 214. And these investigators had some interesting findings. The patients who were assigned to tight glycemic control had a reduction in their ICU length of stay, which was the primary clinical outcome for this trial. They also had a reduction in inflammatory mediators, and interestingly, a reduction in mortality. So the tight glycemic control group mortality was 2.6% versus 5.7% in those patients who received conventional care. However, this came at the expense of an increased rate of severe hypoglycemia, so glucose levels less than 40. That rate was 25% in the patients who were assigned to tight glycemic control, which obviously raises concerns for neurodevelopmental outcomes. And I'll get back to that issue in a moment. While I was still in Boston, I worked with a group of investigators, including Michael Angus, on a two-center trial that we put together to study this issue. So this was a prospective randomized clinical trial. We enrolled patients who were less than 3 years of age requiring cardiopulmonary bypass, and they were assigned to either receive tight glucose control with a target of 80 to 110 or standard care. For the surgical audience, I would point out that the tight glycemic control intervention was started in the CCU early after surgery, so we did not do this in the operating room. There was a computerized insulin dosing algorithm that was used to determine how much insulin the patients would receive, when the glucose levels would be checked, when rescue dextrose should be administered, etc. And we also used a subcutaneous continuous glucose monitor to minimize the chances that these patients would develop hypoglycemia. The key findings from that trial, which were just published in the New England Journal last fall, are as follows. The primary outcome for this trial, after much debate, we decided was the rate of infections per 1,000 patient days, and we found no statistically significant difference in that rate between the two treatment groups, nor did we find any difference in a variety of secondary outcomes, some of which are listed on the slide, including days of mechanical ventilation, intensive care, or hospitalization. We looked at several organ-specific endpoints like arrhythmias, development of renal failure. There was no difference in outcome between the two treatment groups. And although the POWER study wasn't designed to test this hypothesis, there was no difference in mortality, which for the hospitalization was 2% in both treatment groups. We did find that severe hypoglycemia was more common, not surprisingly, in those patients assigned to tight glycemic control, and this was defined as a glucose level less than 40 again, so 3% in the intervention group versus 1% in the standard care group. So what would explain the discrepancy between our findings and this study, this pediatric study from Leuven? Well, I think there are a number of angles that people could look at here, but the things that stand out to me when reviewing the literature is that when in contrast with the Boston study, and the average glucose levels in the early postoperative period are shown here in the lower figure. The red line is the standard care, the red line is those patients assigned to tight glycemic control, and the blue line is standard care. There's not an awful lot, especially after the first 24 hours, awful lot of separation between these two groups. So even patients assigned to standard care are close to being normal glycemic within the first 24 hours after surgery. In contrast, in this study out of Leuven, again, the majority of these patients were children undergoing cardiac surgery. There was greater separation both in the infants, which is reflected on the left-hand side of the figure, and the older children who were in this study. There were also some differences, and this has been pointed out in the adult trials as well, in terms of rates of mortality, which was overall higher in the Leuven study, and the fact that of those mortalities, the excess mortality seemed more attributable to severe neurologic complications and refractory respiratory failure. And some people would question whether those outcomes were related to glucose control versus other factors. Whereas the mortality and the infection rate overall was very low in this in the study that we conducted in Boston and Michigan. So there are a few ongoing trials that we are eagerly awaiting. Most notably would be the so-called CHIP trial, which is a randomized trial of tight glycemic control that's being conducted in multiple different pediatric ICUs in the United Kingdom. There are 1,500 patients that have been enrolled in this trial, approximately half of whom will be recovering from cardiac surgery. And the enrollment for this trial has been completed, but the results, to my knowledge, have not yet been released. There's also the so-called half-pint trial, which is going to enroll nearly 2,000 medical pediatric ICU patients in the United States, but unfortunately cardiac surgical patients are being excluded from this trial, in part because of the findings of the Boston, Michigan study. And then finally, there's a trial that's ongoing at Emory, both in their cardiac and regular pediatric ICU, that's going to enroll over 1,000 patients, and they're in the early enrollment stages of that study. So I think we're going to learn more about that in the years to come. My experience in being involved in this trial in Boston is this is a fairly labor-intensive and potentially costly effort to not only achieve tight glycemic control for these patients, but also to avoid hypoglycemia. So we had a bedside laptop computer that had a computerized algorithm to help the nurses work through this process. We also used a continuous subcutaneous glucose monitor. Like I mentioned earlier, these monitors are pretty good, and we and others had studied that carefully for accuracy compared to more standardized measurements of blood glucose, but they're not perfect. So this hypoglycemia issue is a concern for all of us who've been thinking about this issue. There are now some neurodevelopmental follow-up data from the 700-patient Leuven trial. So these investigators brought as many of these study patients as they could, which was the majority, back for neurodevelopmental follow-up at 3 years after they received the intervention, and they found no difference between the tight glycemic control and the control patients in most indices of neurodevelopment, and in fact in a few indices in motor coordination and in cognitive flexibility, the patients who got tight glycemic control actually did better. But importantly, they very carefully, by several different ways, looked at those patients who had severe hypoglycemia with a glucose level less than 40 and found that they had no worse neurodevelopmental outcomes compared to the patients in the study who did not have severe hypoglycemia. So that is somewhat reassuring. There are a number of recent guidelines that have come out in the last 2 years or so following the completion of all these adult and pediatric trials. The Institute for Healthcare Improvement recommends keeping glucose in ICU patients less than 180. They don't specify children versus adults. For patients who have sepsis in children, the recommendations based on very weak evidence is to keep the glucose less than 180. And there was a recent publication in Critical Care Medicine. There was a group of multi-center group that put some guidelines together, and for children they recommend somewhere between 100 and 180. So we're not sure quite exactly what the right target is for children undergoing cardiac surgery at this time point. So I think the key take-home messages for this group are that intraoperative hyperglycemia, while it's common, hasn't been associated with harm either in our study or several other studies from Philadelphia and others that have looked at it. You can probably ignore it. In the postoperative period, although many observational trials have found strong and independent associations between hyperglycemia and adverse outcomes, the clinical trial data to date do not necessarily assess that tight glycemic control is associated with better outcomes, and there's obviously this risk of hypoglycemia. There are some real practical issues with tight glycemic control, as I alluded to earlier. People have estimated the additional nursing workload for a 24-hour period. It can be up to 2 hours a day solely spent on maintaining tight glycemic control. There are many sources of error with these glucose monitoring, depending on what equipment's used and where the samples are obtained from. continuous monitoring, as I said earlier, that may be helpful. Ideally, there would be a closed-loop system where you're measuring intravascular glucose, and then there's an automatic feedback mechanism that would control the insulin pump, but that technology is not quite in development, but not available yet. And another important issue that came up in the last talk is whether all this is going to be cost-effective. And in the current environment, that's something that we certainly need to think of before we devote all these resources to this issue. I'll just finish off with a few slides about corticosteroids and cardiopulmonary bypass. Certainly this is an issue that is really managed in the operating room, but these decisions obviously can impact the way the patients behave in the early postoperative period. So the dogma is that corticosteroids will blunt the inflammatory response and improve outcomes after pediatric cardiopulmonary bypass. There are a handful of studies in the literature that were published, say, between 10 and 15 years ago that showed that administering empiric corticosteroids in the operating room can blunt the early inflammatory response after cardiac surgery. One of these was a study by Ron Bronicky and Dr. Backer and others from our center in Chicago. It's a small study, but a randomized clinical trial involving 29 patients who either got dexamethasone or placebo in the operating room. And in addition to blunting the inflammation, which other investigators shown, they also found some important clinical improvements in terms of fluid requirements, the AA gradient, renal function, and fewer days on the ventilator and fewer days in the ICU for those patients who got dexamethasone. Well, if one dose is good, maybe two is better. The Cincinnati group looked at that, giving steroids both preoperatively and intraoperatively, as opposed to a control group that just got steroids intraoperatively. They did find in the small study of 28 patients that those who got assigned to the two-dose regimen did have some improvement in inflammatory markers and some favorable changes in indices of oxygen delivery and consumption in the early postoperative period. So steroids had been, and I think continued in the early and mid-2000s to be widely used. There were surveys that were published, survey data both from the United States and Europe suggesting that empiric steroids were very commonly used in the cardiac operating room, although not necessarily for every patient and with different dosing regimens. So that backdrop leads us up to some of the more recent data that's been published about this issue that may inform our practice. So this is a study that was done in the South Carolina program by Eric Graham and colleagues. This was a randomized clinical trial involving 76 neonates who were undergoing cardiopulmonary bypass, and they assigned these patients to either get methylprednisolone 30 per kilo in the operating room, or the intervention group got 30 per kilo in the operating room and 30 per kilo 4 to 6 hours prior to surgery. So they were testing the double dose hypothesis. And these investigators, in contrast to the earlier study from Cincinnati, found no difference in a number of early postoperative outcomes, including inotropic score. The creatinine levels and the urine output were actually worse in the early postoperative period in the two-dose group, and there were no significant differences in several measures of markers of inflammation, including IL-6. Sarah Pasquale and her colleagues published several interesting database based studies that are relevant to this issue. This first study was done using the FIS database, or the Pediatric Health Information Systems database. So for this particular study, they had data from 38 programs in the United States, over 46,000 pediatric cardiopulmonary bypass cases. And of these cases, they were able to document that just over half of the patients, 54%, received corticosteroids. And you can see in this figure there's a lot of practice variation. So on the x-axis is the center, and on the y-axis is the percent of patients who were included in this study from that center who received corticosteroids. You can see that some centers give corticosteroids to almost every case, and other centers give it rather sparingly. And what Sarah and her colleagues found was quite interesting. There was no difference between the patients who got steroids and the control patients regarding mortality, although the odds ratio, as you can see here, was going in the unfavorable direction, suggesting a potential adverse effect of the corticosteroid group. Patients who got corticosteroids had a higher adjusted odds of infection and had a statistically significant, and again, following multivariate analysis, a longer length of stay in the hospital, a longer length of stay in the intensive care unit. The study was obviously done with administrative data, so they chose to look at this issue a little more carefully, and especially in neonates, which is obviously one of our highest risk patient populations. So this was a study where the investigators linked data from the STS database and the FIS database. They included over 3,100 neonates undergoing cardiac surgery requiring cardiopulmonary bypass from 25 different centers, and they were able to identify 4 different treatment groups. Patients who got methylprednisolone the day before and the day of surgery, a group who got methylprednisolone the day before surgery, only 12%. About a quarter of the patients got methylprednisolone on the day of surgery, and nearly 40% of the patients got no corticosteroids. And without going into detail in this, there was no adjusted association between any of these steroid regimens and in-hospital mortality, length of stay in the hospital after surgery, length of stay in the ICU, and length or development of infections in the early postoperative period. Although there was a trend for patients who received steroids in the day prior to surgery with an adjusted odds ratio of nearly 1.6, p-value 0.07, for an increased risk of infection with those patients getting steroids the day prior to surgery. So what are the inferences here? Well, I think that the data that recent data on this topic that I've showed you would suggest that corticosteroids have not been shown to improve outcomes at least in my opinion, in children undergoing cardiac surgery. Some of the more recent data suggest there may be an association with increased postoperative infections and postoperative length of stay. Now, and why would this be? This is obviously paradoxical to what we would think that steroids would help with this inflammatory response to bypass. Well, one question is whether we have the right dose of steroids and the right dosing regimen. But another factor, I think, compared to an earlier era, there have been so many other improvements in perioperative care, particularly in the operating room with miniaturization of the cardiopulmonary bypass circuits, with the fairly widespread use of ultrafiltration, modified ultrafiltration, hematocrit management, all of these things. That these improvements may limit the potential for a simple intervention like steroids to improve outcomes, but may also increase the potential for the side effects of these empiric steroids to be exposed. So, at this point, I guess my message to you would be to have equipoise, as was discussed earlier, about this particular issue. I know that investigators have tried to set up large clinical trials with the Pediatric Heart Network and other groups and have run into problems with this equipoise issue. There are 2 ongoing randomized trials that you should be aware of. One is a study going on at the the South Carolina group. They're looking at 190 neonates, and opposed to the previous study where they compared 1 to 2 doses, now they're going to compare 1 dose versus placebo. So there's the primary outcome for this study is a composite morbidity mortality endpoint, and these investigators are also going to bring these patients back for neurodevelopmental follow-up. And then there was a smaller trial ongoing at the University of Alabama looking at the use of a hydrocortisone drip for the first 5 postoperative days compared to placebo. So I think these will both be interesting studies. So I'll stop there. Thank you very much for your attention.
John, thank you very much. I mean, I think these are really important issues. I think the study with the time of delivery is really a landmark one and really may improve the outcomes in a number of patients. And more and more of us are doing fetal consults, and I think sometimes the families ask us, when should we deliver, and now we really have an answer. The glucose thing, it sounds like it's still up in the air, but it doesn't sound like we have to be too focused on this tight glycemic control from what I can see. And I guess you're just wrong about the steroids, so that's... I have one question. How many people in the room use a dose of steroids to the patient prior to cardiopulmonary bypass? All right. And how many do not? So it looks like it's probably 70%, 30%. I think you're probably right about the miniaturization of the circuit. And I see Ross Ungerleider's coming up. Ross, you're going to be our only comment. Chuck, could you start at 1 o'clock? All right. Why don't we, because lunch is supposed to be from noon till 1:30. I think we'll... I'm sorry, it's probably, as the moderator, I've let everybody we've gone too long with the questions, so I think we'll start at 1 o'clock with Dr. Frazier's talk, because that's a really important talk, and we need to be fortified with food prior to it. Ross, one question.
Yeah. John, great stuff.
Question.
I mean, this is, I love that term evidence-based, because it all depends on whose evidence, doesn't it? And, we keep seeking answers, and what you really showed us is we did keep asking the right questions, because then life just keeps presenting us with confusing and ambiguous information. We have to sort it out. It's like if I said to people, listen, the reason airplanes have propellers is to keep the pilots cool, and I can prove that, because if you ever notice that when the propeller stops spinning, the pilots begin to sweat. And that's the way we go about some of our studies. And so I look back at the steroid stuff, and that's why I got up, because before Carl and Gus did that clinical study, back in an era where we had money to do a lot of research that didn't necessarily get funded, we did all this large animal research. We did a lab study. It was Andy Lodge in our lab at Duke that did a very elegant study, because there was something real that was happening. Those of us that were practicing in the late 80s, early 90s saw these neonates just blow up like Michelin babies when they'd get exposed to bypass. Anybody remember that? And we had to try to figure that out, because it got scary to operate on these neonates. And then we started measuring cytokines, and we saw a tremendous effect of giving preoperative steroids in large doses at least 12 hours before exposure to bypass, even better than the animals that were getting exposed to bypass with steroids in the pump. And so that was sort of the beginning of all this. And as you so rightly point out, we're in a different era now. We have miniaturized circuits. Many of our circuits are coded. We're using modified ultrafiltration. I mean, it goes on and on and on. And the question we have to ask is, what was happening then that may not be happening now? And are we really looking at the right parameters? Because there's so much unknown about what's happening. And so I would just caution people to be careful of the propeller analogy and leap to conclusions and say, well, there's the evidence. Because as I've always liked to tell people, the truth is the consensus of perspectives. And there's a lot of information out there that we have to try to find a way to fit it all together. It's great stuff, and I really enjoyed listening to it.
Thank you.
All right, thanks very much, John. That was very productive. I'm sure we all learned a lot from that. Thank you very much. So we'll resume at 1 o'clock. If anybody sees the congenital people, we're going to start 1 o'clock, not 1:30. Thanks.